I'm Jim Taylor, and I lead an organization called Voices of Alzheimer's, which is a dementia patient advocacy organization. And we've been in existence almost 4 years now. And we conduct a series of webinars every quarter. And we've had some really fascinating topics on recently. And we've got another one today, just to keep you guys informed and knowledgeable. We've got three great people joining us this morning, and I'll tell you about a little more about them in a minute. Uh, you may have heard the word ARIA. I have to read my script. This is hard this morning. For the first time when you or a loved one started discussing treatment with your doctor. Maybe it was explained quickly on the consent form. Maybe it came up in a news article that raised more questions than it answered. I've seen several of those. Maybe you're still not entirely sure what it means, like me, or whether it should change the way you think about treatment. That's exactly why we're here this morning, this afternoon. Uh, those who are newer to Voices of Alzheimer's should know that it exists to ensure that the patient perspective drives the conversation about Alzheimer's disease, not just in research, but in clinical care, policy, and public understanding. Progress only matters if people can understand it, access it, and make informed decisions about it. That's the mission behind today's session. We're really fortunate to have three outstanding voices. My friend and medical advisor for Voices of Alzheimer's, Dr. Jared Brosch is a neurosurgeon and assistant professor of clinical neurology at Indiana University School of Medicine. He leads the IU Health Brain Health Program, one of the most active Alzheimer's disease treatment programs in the country. Kathy and Murt McLeod, active patient advocates who know firsthand what it means to sit across the table from his doctor and make these decisions. And that's why they're with us today. Before we begin, a couple of quick notes. You can submit questions at any point in the Q&A box down below, any point while we're still on the air. And this video is being recorded, so you can watch it online at the VOA website. So let's get started. Kathy and Murt, could you introduce yourselves first?
Sure. I'm Murt McLeod. My career was a research scientist, not as in-depth as Dr. Brosch, but I chase bugs for a living. I was an entomologist and worked largely in the field of agriculture, helping farmers manage insect pests and things of that nature in their crops. Um, and we have lived both of us grew up in North Dakota. And I frequently tell people that I'm Murt McLeod and I'm from the middle of nowhere, North Dakota. But we moved here in 97 and started with a seed corn company, Corteva or Pioneer hybrids, if that rings a bell, and spent 26 years working with that organization. It was a lovely, lovely career. I was at one point toward the end of my career, I was a research manager with a research facility of 42 full-time employees, and I managed that group. And every Monday morning, we would have, this is leading into the beginning of wondering, okay? Every Monday morning, we'd have a meeting, and I would go around and discuss with people what needed to be accomplished that week and how we were doing and what kind of help they needed and that kind of thing. And it was a very, very stressful job. And it came to a point where not infrequently in those Monday morning meetings, I would be explaining things and I would just absolutely go blank. And a lot of the people were very kind. They kind of said, "Oh yeah, you're getting old. You're getting old." Um, but most of the time I was able to recover. But one time it came to a point where I I couldn't recover, and I just stood there silent for about 2 minutes, and I just said, I have to sit down. And that was kind of a light bulb moment. And then the other real light bulb moment was on a family vacation down in Alabama along the Gulf Coast. I almost our whole family was there in a resort type situation. And one night, first night we were there, I left the room in the middle of the night. I had no recollection at all of leaving the room. And then I came to a place where I regained, you know, consciousness. I don't know,
Awareness. Yeah.
awareness. And
Okay.
I was in a very small area next to an elevator,
Wow.
and I had no idea how to get back to the room.
Kathy, how are you managing this period?
It's been an interesting time in our lives. We've been married 44 years and we have three children, seven grandchildren. And this part of our lives has been pretty stressful, not knowing exactly how things were going to pan out. But we're so grateful for Dr. Brosch helping us and taking us on as both of us on as his patients.
Yeah, yeah,
It's a familial
We,
diagnosis,
yeah, we
isn't
come
it?
yeah,
together.
From
yeah,
my experience, and I
yeah,
think from
that's
yours
for
We
and
sure.
came
most
in
people's
pretty
as
nervous
well.
and he put us at ease right away, just talking about possible treatments and
Yeah.
possible outcomes and possible side effects. So we felt we were in the right place at the right time.
So,
So,
Dr. Brosh, after that great introduction, anything left to say for yourself?
No, no, not at all. I'll mention I'm a neurologist. I don't do any surgery, not a surgeon, but I do run our Alzheimer's treatment program here at Indiana University, and I always feel a great sense of relief when I can meet someone like Murt at the right place at the right time and get them onto treatment. Again, the earlier the better, right?
yeah,
And part of what we're going to talk about today is that this isn't always, it isn't always a course where there isn't a side effect and that there isn't a problem. And I think it's valuable for people to hear that, Mert's amazing. He's doing amazing, but it was a bumpy road even on treatment. So
yeah,
maybe that leads into where we're heading next, Jim.
Absolutely. And that makes one of the reasons I'm so excited to have Mert and Kathy here is because we want to show that side of what treatment looks like. I can represent another side, which we'll get into, but let's jump in with maybe a little lengthier description of ARIA than most people have had before. So, Jared, could you really start us off and explain to us what ARIA is?
Yeah, I think the easiest way to explain it, and I usually have really terrible graphics on a PowerPoint presentation, but I think the most important thing to think about with ARIA, this word meaning amyloid-related imaging abnormalities, which is really a terrible word to describe it, but the best way to think about it is that everybody that has amyloid plaques and Alzheimer's disease also gets those plaques inside the walls of blood vessels in the brain. And every person with Alzheimer's disease, especially the higher the number of E4 copies that you have, the more likely you've got the plaques inside the walls of the blood vessels. And these things leak. It's just like having a defect in a hose or a pipe. And spontaneously, these little areas will leak. And if we did an MRI scan to everyone with amyloid plaque like 5 or 6 times in a year, we would find these little leaks approximately 10% of the time.
Mm.
And when we use an agent to get rid of plaques, it's really indiscriminate. It's also going to get rid of the plaques inside the walls of the blood vessels. It causes inflammation around the blood vessels. And we get two types of ARIA, right? There's the
Okay, can
kind,
can we hold off on that just a minute?
yeah, sure.
So you said E4. What's that?
Yeah. Before anybody goes on to the treatments, we use a genetic test to look for the biggest inherited genetic risk factor, and we call it apolipoprotein epsilon 4. So we all carried a one copy of this gene from mom and one copy from dad, and we either got an ApoE2, 3, or 4. And if you're depending on the circumstances, you might get an E4 from mom and an E4 from dad, and then you've got two E4s, and that means we've got a tremendously high risk of getting Alzheimer's disease, but it also means we're at a higher risk to have side effects from the medicine. Or another way to think of that is a higher risk of having the spontaneous areas of bleeding or swelling.
Okay, so APOE E4 is the bad gene we don't want. We would prefer to have a 2 or 3. Is that correct?
In general, that's correct. Yes,
Okay.
in general we thought of ApoE4 as increasing our risk of having Alzheimer's disease. And if you have two copies, then you're at a much higher risk than the general population. And for
And
those of you, oh, go ahead, Jim.
what percent of the population has two copies of the E4 gene?
Yeah, it's a pretty small percentage of the population. We're talking about like 10% or less, and I don't have the exact percentage off the top of my head unless one of you guys do.
I think it's like 2%.
Thank you, Jim. Thank you.
Just trying to stump you here. First time I've ever been able to do that, so I'll congratulate myself. And you said 10% referencing. So are you saying that without treatment, an Alzheimer's patient would have 10% of the time would have plaque inside the blood vessel and possibly have ARIA, or clarify that?
Yeah, it's a great question. I gave you that number, that 10% risk of us finding a small area of swelling or bleeding based on clinical trials. In the last 15 years, there have been a lot of major clinical trials, the aducanumab clinical trial, lecanemab, donanemab. When we look at these studies and we look at the placebo groups, the thousands of people who had some mild memory changes and Alzheimer's disease, and we follow those people along and we give them a bunch of scans, 10% of the time we found that they would have a spontaneous leak. So that helps us understand that this is a spontaneously occurring phenomenon.
And I don't think most people understand that. I certainly didn't before you explained it to me very clearly. So without treatment, what we've learned through the placebo group, so that's the group in clinical trials who were not on any treatment, that 10% of the time they had ARIA without treatment.
That's correct.
So that's kind of remarkable, and it's a very good place for us to start in understanding what ARIA is when in treatment. Now we're talking about treatments. A little more background. What are we referring to when we say treatment?
Right now, there's only the two FDA-approved treatments that are available. So there's the lecanemab and the donanemab treatments, and these are intravenous treatments. They activate the immune system and say, go after plaque. I'm not sure why you're ignoring it, but you see this stuff, go get it, right? And it's in a sense, it's almost like a vaccine. I hesitate to say that, but people can have vaccine-related issues when you use it, and in a sense, we're telling the immune system, this is the problem child here. Go get it.
So this plaque is called amyloid, and these are anti-amyloid treatments. And
Correct.
are they available for anybody who has Alzheimer's?
They're only available. They're available for people who have a diagnosis of Alzheimer's where we can measure the plaques. We know that they have plaque present. But when we've used these drugs in the past, and part of the controversy with these treatments is that when we use them in the moderate stages and the severe stages of the disease, not only did they not do anything, but they also caused harm. It wasn't until we did clinical trials in people who were just at the very beginning, having their first memory problems, but otherwise living independently and doing well, or people who are just needing a tiny bit of help to live independently, where we could measure and show that these drugs change the slope of the disease, they change the course of the disease, and help people stay at home longer and have more independence.
Will it make me well?
The drugs don't lead to an improvement. They don't stop the disease, but we know that they can really significantly slow it down if we find the right person at the right time.
So what do you think, Kathy? Did he do okay with those? Well, we got to keep him under the gun here. So he's a wonderful educator. So Murt, when you first heard, when you were speaking with your physician about treatment and you heard about ARIA, what was your reaction? Was
Well,
just pass it off, or did you really think it was something important?
well, I thought it was something very important, but I also, Dr. Brosch explained it very well just now, and he did when I was sitting in the office with him. And I think he told me, 10% of the people get it, and a lot of times there's no impact at all. And so, might sound kind of corny, but my mother died of Alzheimer's, and there was nothing she could do about it. There was nothing doctors could do about it at that time.
So
And, and so my reaction was, well, there is something that can help, and so I'm going to do it. I
so
told you earlier, Jim, in another separate conversation, you asked me about did did the did the discussion around ARIA change my thoughts on a treatment plan? And my response to you was not for 1 minute.
so
And that could be careless. I mean, that's not that I'm not telling anybody what they should do, but that's how I chose to handle it.
and did you think you were at greater risk than average at that point?
Well, I knew I was because Dr. Brosch explained to me that I had two markers, and I
Ah,
believe that you said that that would be a greater risk.
so you are
But I
one of
knew
the
that when I made that decision.
you are one of the 2% of the population that got the bad gene from each parent.
Yeah.
And are those, Jared, are those individuals like Mert specifically identified always? Is that a requirement to receive the treatment, that you know what your APOE status is?
Yes, it is a requirement because it impacts the side effects. And, from the clinical trials, depending on the drug, a person that has two copies has somewhere between a 30 and a 50% chance of having an ARIA event that we can measure. So
Much greater.
there are quite a few places that won't treat a person
Okay.
that has two copies because of that risk.
But everybody who begins the treatment knows if they have two copies. And do you watch them more closely than somebody with one or with no E4 genes?
Yeah, it's a great question. The prescribing guidelines don't tell us that we require extra scans, but we have a very low threshold and we try to overeducate people that carry two copies and say, if you've got a headache and it lasts longer than a couple of days, we want to know about it because you're in this high risk group and we should be prepared to do an off-schedule MRI scan at the drop of a hat because we don't want to miss something.
Mhm.
So you were on the alert when you started treating Mert and Kathy, that they needed to be cautious and you needed to be very responsive if you heard from them at any point.
That's correct.
And how long does this danger period last throughout the infusion period, which is usually, 12 to 18 months on one drug and continuing on maintenance dose for the other drug?
Yeah, in our practice, we treat basically everyone for 18 months, regardless of which drug they choose.
Okay.
What we know about both drugs is that the longer you're on, the lower and lower your risk of ARIA becomes. And the thought process is generally that, as you clear more and more of the plaque out, then we're going to have less of those leaks that happen.
Okay.
And so most people have ARIA events within the first 6 months, and then the risk drops way off, but do see people who will have it later on too.
So Kathy, when you heard Dr. Brosch explain to Mert what the risks were you as determined as your husband to proceed?
Well, I can't say I was tickled pink about it. I had a fair amount of reservations and I was very concerned because he did have both protein markers that it may lead to a higher rate of this happening to him. And I kind of envisioned more of a stroke kind of thing happening to him in my mind. That's how I kind of perceive things. And I thought, oh, babe, I don't know. I feel a little uncomfortable. And he was ready to jump in the next day and start everything. But I had some reservations for a while.
So are you usually the more cautious of the two?
No. No, I'm usually a jump right in. Let's try this. Let's do this.
No,
And
I just
I
think
was
that's
nervous.
it's interesting.
Yeah,
So
everything was so new and it was all coming at us so quickly that I'm still kind of shaky just talking about it.
so I think what Dr. Brosch has explained to us that there are a certain group of people who we know are at elevated risk. Now, Jared, we clarified that for the two. What if I'm just one APOE4? We know that Mert's obviously very exceptional person, and then that very small group of people who have the double fours. But what about the single fours that have E4 gene from one parent? Are they at greater risk than the person who has no E4 gene?
Yes, yes, that is correct. So, just having a single copy, which we call a heterozygote, that's a person who's going to have a higher risk. And if we look at absolute percentages, again, it depends on which drug, because there are differences in the side effects between the two medicines. But if we look at the lecanemab group as an example, those individuals, we would go from about a 5 to 6% risk overall of ARIA to about a 12 to 13% risk of an ARIA event, whereas the double E4s are going to be in that 30 to 50% range.
Okay. So there is a elevated risk if we're just one. Uh, would you say, do you watch those individuals more closely, or do you treat them with the same procedures as a person without any E4 gene?
Yeah, it's a good question. I mean, we tend to treat everyone the same. There is no difference in the prescribing guidelines or in the expert recommendations for these folks. There is an optional MRI around a year, which we find, and we have most people undergo, but definitely if we have a copy of E4, we're much more likely to say, hey, you should get this optional MRI at a year too. But we counsel everyone the same way. Just here are the things you might detect from a symptom standpoint, and we will do an off-scheduled MRI for those folks too.
So if I could just summarize what I think we've learned is that the anti-amyloid treatments that removes a plaque or a protein called amyloid from your brain, in which most of the treatments last 18 months, are successful not in curing or reversing the disease, but they slow the progression, only available to the early stage patient. We know that a number of those patients have at least one copy of a dangerous gene called APOE4 that elevates their risk somewhat versus people who do not have the gene, and that there's a select group of double E4s, so both parent gave them the bad gene, and they are at the highest risk of developing a side effect or some called ARIA. So Mert, you were one of those people who did experience side effects, if I recall from what you told me. Is that correct?
Yeah,
And tell
when
us about that. What was that like for you?
when we started the program, I don't remember Dr. Brosh, but for every infusion for what seemed like quite a while, I had an MRI after those when we first started out. Is that correct? Yeah. So um, I had only one MRI out of probably 12 to 14 that showed any um, sign of ARIA. Uh, uh, I um, and the factor there was there were couples very small, but they showed up on the MRI brain bleeds. And then um, after that, the only other thing that I had was there was one time I had a infusion. Everything felt fine. And I came home and I had just a horrendous headache that evening. But it was short-lived and it wasn't like for days and stuff like that. So my experience with that was not a frequent thing. Like Dr. Brosch said earlier, a low percentage of times when that magnified itself in my experience. I'm not saying anything about what could happen with
Of
other
course,
people.
right.
So that
So
was
how bad did it get then? Was the headache the worst part, or was there anything worse than that?
it. The headache was the worst part. My head was just like
Pounding, huh?
pounding.
Yeah.
And it wasn't the same infusion where the two little blood bleeds were detected.
And did you call the
Yeah.
practice or Dr.
Mhm.
Brosh?
Yeah, we
And,
called Dr. Brosch as
and did
well.
he make a home visit?
Well,
Yeah.
you get out of
Yeah.
him what his favorite dinner dish is, and maybe I could get him down here with help from my friend here. Um, no, but it was just a really bad headache, and it lasted.
Shakes
Hmm?
and shakes.
And some shakes. Yep.
So, would you call those convulsions?
Um, there were times I would call them convulsions because there was a time when there was one that was um lasted a lot longer than another one.
Now,
So
Jared, that's pretty concerning. Is that typical of of a homozygote, or
Yeah, and I don't want to confound two different things here. There
yeah,
and I don't remember exactly how your course went or how much you want to share, Mert, but we deal with the reactions to the infusions
yeah,
primarily up front in the first several infusions where we're
yes,
having almost like a vaccine response to those first few
right.
infusions. And then we've got the symptoms from the ARIA events, which are separate. And maybe Mert, you can explain the difference between what you experienced with the infusions and then what you experienced with the ARIA.
The aria was and I'm calling the one. The time that there were a couple little ticks of blood in the brain. That one, that wasn't a physical, well, it didn't cause physical pain actually.
asymptomatic? Yeah.
Yeah. And, but there were times, and again, like you said, because of the, the stuff that's being applied, I would have tremors and shakes and things of that nature. They didn't last very long. The first one was probably the biggest one. And then there were other times I would get home from the infusion, only an hour drive, and then I would start shaking and tremoring a little bit.
So,
Yeah.
Kathy, how was that for you?
Terrifying. But Dr. Brush prescribed what we kind of called a cocktail before his infusions. It was three different medications. I don't remember
Yeah.
Pepsid and uh, Tylenol.
Tylenol,
What was the third one, Doc?
There's a steroid.
Steroid. Yeah,
steroid.
steroid.
Yeah.
And then his infusions became much less
Yeah.
stressful because he kind of almost slept through them.
Yeah. There
But
was
that
there was
cocktail, a little
yeah,
Bloody Mary and
they
mixed in there
did
too,
they
huh?
I don't know if they're telling. No, I'm kidding. I'm not going to joke about that. But no, that took care of it for a very long time.
Great. So,
And then
Mert, why didn't you quit? Did you consider giving it up? I mean, that couldn't
I
have been
did.
fun.
um, Kathy was, rightfully very frightened by some of those instances. Um, but again, I don't know, maybe I'm a selfish pig, but it delays the decline. And I guess I was willing to take that risk for that. And
I,
that is not advice to anybody else that hears
no,
this podcast.
no. But Mert, I think so my own background was my wife had Alzheimer's, didn't have the good fortune of having Dr. Brosch, but we had good medical treatment, and she was on the anti-amyloid treatments. And she was also in the rare class, as you are, of a double four, APOE4. So the 2% of the population that get the bad gene from each parent. She was on treatment for 7 years because it was a clinical trial and they wanted her to
Um,
stay on it to see what the longer term impact was. She never had any sign of ARIA.
wow.
So there it is,
Yeah.
you're a double
Yeah.
four, she was a double four, and she was, loved being on the treatment. We realized she was really doing well. But I think what a lot of people don't think because they can't walk in our shoes and my shoes are not your shoes, they're more Kathy's shoes, the high heels. But, I think people don't realize that we have been given a death sentence. We have been diagnosed with a fatal illness.
Yeah.
And your perspective of risk changes the minute you hear that diagnosis. And therefore, if you see a lifeline, it's much more perhaps valuable to you than it was before you had received that diagnosis. So that our risk tolerance, I think, rises. And I think, people who want to make that decision for us and say, no, you shouldn't have that disease because it's too risky, don't give us enough credit and don't understand that we have a different perspective than they do. So I'm preaching to the choir here, but I really feel this very, very strongly.
Yeah.
So, Dr. Brosch, Mert shared some pretty challenging reactions. Have you seen this? Is he the only one you've ever seen in this situation, or is this not unusual for a double four?
Yeah, I think from an infusion reaction standpoint, which is how we term it, but I think it's really sort of a natural response to this drug that really amps up the immune system. We've seen a lot more of those reactions that Mert described, the shaking, the chills, sometimes even a delay after you get an infusion and you end up at home and start to have those things than we expected. In the clinical trials, the rate of those reactions was lower. And in the real world, we're seeing them somewhere around the order of 40 to 50% of the time. And based on the
For
severity,
double fours?
that for everybody. And so this is, we don't, we haven't made a connection between the E4 carriers and the infusion reactions. That
Okay.
doesn't seem to be super clear.
So you're telling that 40% may have these reactions once they get home of the headache and the shakes?
Yeah, a lot of it is like chills. We call them rigors, which
Rigors.
would be like that shaking, convulsing. And I hesitate to say convulsing because they're not seizures, but it is sort of that really serious shakiness, like we were coming down with the flu.
Yeah.
And as Mert described, it doesn't necessarily last a long time. It's not like we're down for days because we got chemo. It's an hour or two or three, but it can be really scary.
It can
And
be.
we've had people go to the emergency department and we've scanned them to look for ARIA and it's not there. It's just a really strong immune reaction.
Right.
And what Mert described later on, that he had a couple of microhemorrhages or ARIA-H and he didn't feel anything. That's really
Yeah.
common. Go ahead, Mert.
No, I was just saying yes. That was because when Meredith called and said that, or maybe it was an office visit with you. Um, that was a treatment that had no physical effects at all, but yet it happened. Yeah.
So just
Yes,
to clarify, this post-infusion reaction is not ARIA.
correct.
Wow.
Correct. No, that is, it's very typical, like you heard, somewhere in the 40% range for at least lecanemab. You
And
know,
did you create this cocktail?
so I can't take all the credit for it. We have some really brilliant pharmacists
Baristas.
that I relied on, and in fact, one of the things that people love to do in an infusion center is give Benadryl, and we all kind of know that Benadryl isn't good for our memory and it's sedating. And so our brilliant pharmacists said, in when we give chemotherapy or people have brain tumors, we use Pepsid, and we can have a very similar antihistamine sort of reaction with Pepsid, but we don't have the hangover. And so a lot of thought went into what exactly should be in that cocktail so that a person with memory loss doesn't walk away with more memory loss after their
Mhm.
infusion. Um, but the steroid treatments are used for people that have really serious responses, and usually we'll use it for a few treatments and then try and come off of it.
Yeah.
But some of the newer drugs that are under development, they give a steroid every time, just because we know that it really, really turns the immune system on. So there's lots of different approaches, but that's been a general approach for a lot of folks.
Help me remember to come back to the next generation of these anti-amyloid drugs because that's exciting news as well. I
Yeah.
interrupted you earlier, Dr. Brush, when you were
No.
going to explain that there are two different types of ARIA, ARIA E and ARIA H, I believe. Could you,
Yes.
uh, do we care? Why does it matter?
Yeah, great question. Great question. Yeah, there are two different types, and one type is a type where we get a little bit of bleeding, which we call ARIA H, like hemorrhage, and then the other one is ARIA E, which is a little area of swelling.
Mm.
Most of the time, when we get microhemorrhages, which is, what Mert was describing, these tiny little pinpoint areas where we can see a little bit of iron from where there was a leak of a drop of blood, that gets healed up so fast
Mm.
and it's so small that most people don't have any symptoms at all. And so when we call people and tell them, hey, we found this thing, we're going to pause your treatment and then scan again in a month, we really don't expect to hear that they are having symptoms. And many people are like, I don't feel anything. Are you sure you need to pause? What's going on? But when people have the swelling kind, we're a little more likely to hear
Okay,
about
so
symptoms.
wait, the first one you said was E or H?
H, the bleeding kind, a microhemorrhage,
Okay.
H, hemorrhage. There is a scarier form of ARIA H. We call it superficial siderosis. And you don't have to remember this, but there can be larger areas of bleeding, not just the little pinpoint things.
Mhm.
And when we see one of those larger areas of bleeding, then that's one of the indicators that we have to stop treatment no matter what. We don't get a three strikes and you're out rule. It's this happened, this could be a lot worse. We're not going to do it. But most of the time, we just get those little tiny, we call them punctate areas of microhemorrhage. And then the second kind of ARIA is the swelling kind. And obviously, you can imagine if there's an area of your brain that's swelling, you may be more likely to have symptoms. And so we do see more symptoms with that, and it's often a headache, a lot of times in the back part of the head. It doesn't go away like you would normally expect for a regular headache. Sometimes there can be more dizziness or vision changes or confusion associated with it. But it is also reversible, just takes a little bit more time, and the same practice is put into place. We pause, we do another scan in a month, we make sure that it's gone away before we would restart treatment again.
So when you say we pause, that means the patient forgoes getting one of their infusions as regularly scheduled,
Correct.
or maybe two, or do you?
Yeah, it really depends on what we find. But
Okay,
in a lot of people, it's they will miss a month's worth of infusions. That's either
okay.
one donanemab or two lecanemab
Right.
typically.
Good point.
Hmm.
Mert, you had a rough time there a couple of times.
Mhm.
Um, Did you feel that your physician, whoever he or she was, had adequately informed you and prepared you for that occurrence?
Yes. I, as I said earlier, it was described
Yeah.
very well,
And
and I just kind of forged ahead anyway.
um, looking back, I'll ask you and then I'll ask Kathy. Would you have done anything differently had you known what the path was?
Well, I felt like I knew the path was not going to be smooth. There were going to be times when it was rough. And that was explained to me. I mean, the numbers are there that Dr. Brosch has. And again, um, I I almost felt, this sounds weird, but my mom didn't have a choice. And I thought if I did nothing, I was letting her down. I know that sounds
Oh,
really weird.
oh, Mert, not at all. That is so beautiful. Thank you. Thank you for sharing that with us. Thank you. That's why I love my job, Mert. So, Kathy,
Mhm.
if you had it to do over again, or how would you advise somebody beginning? You had a rougher time emotionally, I think, than Mert, which we kind of understand somebody who doesn't have the disease versus somebody who does. Did you feel that you adequately understood what might happen?
I definitely felt like I understood what might happen, and that's what got me uptight about some of the reactions he had. But in fact, I even tried to talk him out of it. After a few reactions, I took him to the
Aha.
emergency room twice.
Yeah.
So I tried to talk him off the ledge. Maybe we should just, take a break from this for a while and talk to the doctor again. And then he said, I might cry. He said, but I want to celebrate our 50th anniversary. I said, let's keep going then. Let's keep going.
That's beautiful. You know, thank you both. I can't thank you enough for the openness and the honesty because that's what reaches people. That's when people begin to understand, is when we can be as open and honest as possible. Dr. Brush, are all your patients this brave?
Definitely not. No, no. And I think if I recall, Mert was one of the first people with two copies of E4 that we offered treatment to,
Oh,
and
wow.
we were we were really anxious ourselves, right?
Yeah.
Um, and I think what made it easier for me and my team too, who had their apprehension, was that Mert was just so strongly opinionated about it. He's like, what have I got to lose? This is the way forward. And we appreciated that, but I think we all went in, and I probably talked those percentages up even higher than what I just said today. And in our real world data that we just published and is in press right now, we've had a 33% ARIA rate in all of our double E4s, and we've got 12% of everybody of the 300 some people that we've treated are E4, just like Mert. So we're seeing,
12%.
yeah, we have
Wow.
12%. In the clinical trials, they had about 15 to 16% in the
Okay.
original clinical trials, just because we're not talking
They're
about the
most
general
likely to
population.
develop. Yeah,
We're talking about the people who already have memory problems.
right.
Yes. I think his bravery really kind of helped us through getting
Educate.
that part of our program started. And I think this has been really successful, I think, for Mert. I don't want to steal any of his thunder, but I know it was a really rocky road, but it feels to me like this was a wise, brave decision that has panned out.
Mhm.
So, yes.
I won't take any credit for being wise, but um, I, I, I and Kathy really feel that these treatments are doing good work.
Now, are you still on treatment or have you concluded, Mert?
Well, no, I'm still on treatment. I had the 36, and then there was I think, did I have 6 more months of
Yeah, I
that?
had 12.
And now we're on maintenance
Maintenance.
treatments once a month.
And those are, is that injectable or is that still an infusion?
It's an infusion. I mean
Okay.
that I don't know. Dr.
Yeah.
Brosch maybe has injections, but I'm still doing infusions.
Okay.
And this is another kind of testament, I guess, in terms of optimism, is that I have friends and people I know and have known all my life. And when I tell them I have Alzheimer's, they just
They
say,
don't believe it.
no, you don't.
Yeah.
You don't. No,
Yeah.
there's
You
no
couldn't
way.
have.
Right.
Uh,
But I,
my wife used to get annoyed at that a little bit because it was like she had to convince them she had
yeah,
Alzheimer's.
right.
Yeah, okay,
Exactly.
excuse me, but yeah,
These people that I'm speaking of are not all scientists.
like you are. Okay, Jared, back to you. Uh, so tell us about the next generation of anti-amyloid. Are you excited about the future and how will they be more comfortable or a lot of risk or
Yeah, great question. Yeah, and you brought up a point, at least one of the drugs, the lecanemab drug that is available is now available as an injection, but there are um, some caveats to all of that. And it depends on your Medicare plans as to whether or not it's super affordable. So there may be some additional deductibles that have to be paid in Medicare Part D. So it's a case by case, but that is an option now.
and that's an at-home
That's
injection.
an at-home injection.
So
So
much more user-friendly.
so instead of going in and getting an IV once a month, you could give yourself an injection once a week at home.
Mm,
And again, there is a cost differential there. So it's something that we're offering to folks now and depends again on a lot of factors as to who takes that. This is going to be a really upcoming, exciting month, and I know Jim and I are going to meet in person because we're going to be at the Alzheimer's Association International Conference, and we get to hear
okay.
about longer term data from the people who have been on lecanemab and donanemab, and that's going to be really exciting. So that's a major development that we always look forward to, and some really cool modeling that I'm aware of, looking at what sort of time savings, what sort of delay are we really causing if we catch someone at the right moment? So that sort of information is upcoming. In terms of the pipeline, there's a couple more of these amyloid treatments that are coming out. There's an investigational drug from Lilly that's an injectable medicine that you might not have to use but once a quarter, which would be really interesting and exciting. There's an interesting drug from Roche that seems to clear the plaque at 3 times the rate and
Mm.
have only a 5% ARIA rate. So
Wow.
there's
Wow.
some excitement these are still under development in phase 3 studies now for both of them. But we're excited to see how these play out. And then, of course, there's a lot more to Alzheimer's than amyloid, and we all know that. And there's anti-tau drugs under development, drugs that help the immune system, a variety of different treatments that are under development. But the ones I mentioned are the ones that are the closest to the finish line.
Mm.
Okay, this is a trick question because I know the answer and you got it wrong last time. Are there any combination trials that you're aware of?
There are, yes. So there are a couple of them. One of the combination trials that we're watching is in the group of people, and I mentioned this in the question and answer group as well. There's some people who carry a genetic mutation that's different from ApoE4. It's a gene that guarantees if you have it, you're going to get Alzheimer's, and it's going to be at an early age. And that group of people is being followed along, and they're getting a combination of amyloid treatment and tau treatment at the same time to see if that might have a bigger impact. And so that's one of the major ones. And then we're seeing more and more studies for drugs where they say, hey, if you're on lecanemab or you've been on donanemab, we still want you. We still want you to try this other medicine that might support the connections in your brain or that might go after the tau. So we're seeing a lot more trials that aren't true combo treatments, but they're saying, hey, we recognize that people are being treated with these amyloid drugs and we want to still include them.
And what about devices?
Lots of excitement with devices. Um, there are devices that are looking at sort of magnetic stimulation outside of the brain to see if we can support synaptic health, different electrical techniques, and a variety of other things that are coming out in that sense.
So I should share that a year ago, Dr. Brosch and I were together, and I saw some of these devices and was very impressed. And so he was a little skeptical, didn't have the insight I did into these technical matters. And so I asked him to check, there's two different companies, and I asked him to check them out. And he came back to me, how many people have a genius like Dr. Brosch to check out with it? And he came back and said, really, he was impressed and would be watching them. But it's a great combination possibility, combination trial. So just hearing all this, does that make you hopeful? Kathy, does that make you hopeful? Doesn't it just thrill you to hear this?
It absolutely does, because we know that it will affect our children and our children's children, possibly. So we're all for this. I'm on board now. I was shaky and nervous to begin with, but
He was
I'm so grateful.
just afraid,
Just afraid.
not against
Of
them.
course, of course. And so you know that your children each have at least one gene, which increases their risk of developing the disease, as does my wife's son. We've really had a wonderful, this is one of the best conversations we've had, but I better pause here. Susanna, do you have a question? I can't very well monitor the Q&As, but are there some that we should try to address in our remaining 8 minutes?
Yeah, I think Dr. Brosch already answered a couple of them in the chat, so thank you very much. But if there are any other folks that have questions, please submit them in the Q&A function, and we're certainly able to address those. But for now, I think everything seems to be answered, which is great.
Great. I saw somebody in the chat had asked whether or not they could get a ticket for AAIC. I think it is, if you can go to London if you want to, but
Oh boy.
it's pretty expensive. Or you can sign up and I believe attend most of the sessions or the sessions that you choose, because multiple sessions are concurrent, are at the same time. And you can go on the web and see most all of it is broadcast, which is kind of remarkable to think how far we've come since COVID. You would never have even considered something like that. And it's a much reduced rate. But I'll tell you, I've learned a lot, but I have a hard time going into many of these presentations and understanding what's being discussed and talked about. They are pretty scientific. Dr. Brosch doesn't have that problem, so I try to tag along with him whenever I can and have him explain it to me. So, but this is there's several major scientific conferences in the year. There's another one in November that will be in Boston. These happen every year, but the one in Boston is just Amazon. Where did that come from? Alzheimer's. It is not related diseases. And the one in London this year is much larger and includes related diseases as well, which is exciting because it's only Alzheimer's that we now have a treatment that will slow the progression of the disease. And of course, we know that Alzheimer's is 2/3 of all dementias, but we really want those other smaller related dementias to progress and have treatments as well. What age were you, Murt, when you were diagnosed?
I was diagnosed in October of 23, so I was 63 years old.
Okay, so you weren't eligible for Medicare.
No.
So one of the things I want to put a plug in is that for all people who are diagnosed younger than 65 with Alzheimer's or young onset Alzheimer's patients, they have to wait 2.5 years to
Yeah,
qualify for Medicare. And that delays the time in which most people cannot afford it on their own, and commercial insurance is pretty spotty. But after that wait, they really missed a very important treatment opportunity. They may well be out of the early stage and not able to get treatment at all, or they may be much later. And we know that, I think, Murt, one of the reasons I assume it's been so good for you is that you got, Dr. Brosch said, at the right time. Sounds like you were one of those patients that we caught at the right time, whatever that time is.
it was the Alabama, what'd you call it? Defining moment.
Yeah, it was.
It was a horrible night, but it
Yeah.
was a blessing, actually,
Jared?
if I can say it that way.
Yeah.
And I'm so happy to have been able to help you, Murt.
I'm so happy too.
Yeah, and as Murt described too, these treatments do have other risks, and Sam in the chat mentioned that there was a serious bleeding event that he had as a result of treatment, and there are people who have more serious consequences, and part of what we're learning and part of what Murt has been a pioneer in and Sam has been a pioneer in is we're trying to understand who's at the highest risk and what don't we know and what blood tests do we need. And I know when Murt comes in, he gives us extra blood so that we can try and figure these questions out. Or
that gal bled me quite a bit for a while.
Right. So there are still a lot of unknowns and things that can happen. And so thanks, Sam, for your comment in the question and answer.
I'm so grateful for what we've been able to share this morning. I also want all our viewers to know that Medicare situation for young onset patients can be solved if we support and pass a bill that's now been introduced in Congress called the Bridge Act. And this would give immediate full Medicare benefits to young onset Alzheimer's patients. And the justification is because that delay may well preclude them from even getting treatment. So we want to be sure that young onset, like Murt, but many of these young onset individuals are in their 40s and 50s. It's just so tragic to see them taken and diminished during the period when they have young children at home or at the height of their careers and earning power. And it's really something that we can avoid. We have a precedent. ALS is exempted from that waiting period, and now we have to get young onset Alzheimer's. So everything we can do to call your congressman. If you go to if you go to our website, voicesofad.com, we have a whole section of our website dedicated to this Bridge Act and to a number of the other things that we've talked about this morning. I can't thank the two of you enough, the three of you enough. It's really been a wonderful conversation.
It has. I've learned a lot this morning too.
Me too. And he got so many answers right this time. That's really good.
Yeah.
He's coming along. Just want to remind the viewers that this is being recorded and you can watch it on our website in the future. If you didn't get everything, which we gave you a lot to understand if you're not pretty familiar with this science. And it has taken me a long time to become familiar with it. And it gives me a lot of joy now to be able to talk with people like Dr. Brosch and with Murt and Kathy. So thank you so much for turning in today. Thank you so much, Jared, Murt, Kathy.
Thank you.
It was
Thanks,
a
Dan.
wonderful
Thanks,
hour.
Doc.
My pleasure.
Yeah.
Bye, guys.
Bye-bye.
Bye.